options. We would like to proceed with Mr. Stavropoulos and his speech about new anti-obesity drugs.
Είναι έτοιμη να παίξει. Okay. Thank you all. I would like to welcome our distinguished surgeon, Dr. Mohammed El-Kalawi. I would like to thank the scientific committee and the surgeons, Anastasopoulos and Kondoradis. I'll try to approach the pharmaceutical body weight management. Some general knowledge. This is not a very prototype. You've seen this map twice today, showing the global impact of obesity in adults, especially around the Mediterranean Sea. And now there is global trend rising through the years, and we can see also a rising trend in children and in adolescents. This is something we should keep in mind because nowadays we treat adolescents with body weight lower agents. Greece would not be an exception to all this. Two-thirds of the population are either obese or overweight. Okay, we have the BMI as a standard. This is rather a convenient way to define obesity than accurate. I would suggest that we should undergo to direct body fat measurements additionally. Obesity is not coming alone. Some of these complications or comorbidities are overlooked, like obstructive sleep apnea, knee osteoarthritis, and PCOS for women and fertility problems. And this is another topic that is often overlooked. We're talking about cancer. There is clear relations with many types of cancer. You see here the increasing risk for certain types of cancer. And you can see the similarities of this map with the previous map. Areas of the world, countries with obesity have a high proportion of cancer cases attributable to high BMI. And in numbers, we see the esophageal adenocarcinoma in males and females. And we see the endometrium cancer in females. Oh, this is pretty amazing slide because if we had the same prevalence of obesity as we had in the 80s, we would have avoided 1/3 of the cancers related to increased BMI. All cancer death increases with BMI. And we see the higher the BMI, the worse is the outcome treating a cancer. So after all this, there's no doubt that obesity is a chronic disease, and we should treat like all chronic diseases with long-term medication or surgical intervention if needed. And now a few things about physiology. There are several studies showing that we have modest efficacy with lifestyle interventions. And the worst is that we have a regain and we set a new point over baseline after a few years after the lifestyle intervention. Okay, obesity is pure biology. There are hundreds of genes affecting the outcome. There are certain peptides who stimulate brain, and specifically the hypothalamus in certain areas of the brain. And many of these peptides are therapeutic targets. We know GLP-1 is a therapeutic target. We know soon we will have amylin and PY3. Okay, how did this all start? All began with the description of incretin phenomenon. We provoke the same glycemia either with glucose intake or intravenously. We saw that the result was a different secretion of insulin. We had more insulin secreted when we gave glucose orally. That led us to have the theory that there is a substance which increases secretion of insulin, and we name it incretin. First, we discovered the GIP human incretin, and then the GLP, the GLP-1 human incretin, which actually it is the gene, the glucagon of the gene of glucagon codes GLP-1 is the same with glucagon and expressed in the gut. Here we have the GIP and GLP, and DTP4 enzyme, which blocks, inactivates, degrades the GLP-1, and was the first attempt to boost the endogenous GLP-1. Of course, there was no efficacy with DTP4, but there was efficacy in diabetes with blocking the DPP4 enzyme. And this is remarkable because we see that most of the insulin secreted is due to GIP and GLP and not due to glucose. 2/3 of the insulin secreted are dependent on incretins. So what is the GLP-1? You can see this peptide. We have already it is already demonstrated all the effects of GLP-1. We see there are receptors in the brain, in the lungs, in the heart, the pancreas, kidney, GI tract. GLP responds to food intake, reduces energy intake, increases satiety, and reduces hunger. The GIP has a major role in facilitating the storage of lipids in the right tissue, which is the muscle tissue, reducing the visceral fat. I must say that the mechanism of GIP is not clear yet, and there is more to understand about it. And as already we've seen, everything is in the brain. GIP and GLP activate certain nerves and centers in the brain. Knowing the physiology, the next reasonable step was to make medicine boosting GLP-1 level using exogenous GLP-1. The first GLP analog that had notable weight loss efficacy was liraglutide, which is still in use. But the first which had meaningful weight loss efficacy was semaglutide. And with tirzepatide, later, we had a new era on lowering weight. Here we can see how the benefits of GLP are agonists. Not only they are beneficial in terms of losing weight through the mechanisms described above, but they also have benefits enhancing the natriuresis, reducing the inflammation, reducing fat accumulation in liver, increasing insulin sensitivity of muscles, etc. So we must focus now on two most efficient agents, which is semaglutide and tirzepatide. This is semaglutide. It's a human analog of GLP-1. Semaglutide has multiple benefits apart from reducing body weight. We have with semaglutide less hunger, better fullness, increased satiety, lower food consumption. You can see it in this slide. And here we can see that semaglutide has a very early effect in the first 20 weeks. Consider that the first 16 weeks are the period for titration. The benefits of semaglutide are evidenced through two big trials, the STEP trial and the SELECT trial. STEP trial had 5 arms. Step 1, you see the demographics here. Actually, it was semaglutide 2.4 milligrams versus placebo. There was lifestyle intervention in both groups, and we checked the efficacy. There were subgroups with several comorbidities in the study, and we saw the change in body weight. It was about 16% of the body weight, and we can see that 34% of the group achieved a goal over 20% of losing weight. More 34% lost more than 20% of their weight. And here, body weight changes by sex. Males lost 16%, females, 16% for the females and 11% for the males. Significant reduction of waist circumference as well, and reduction of the CRP. Significant reductions in fasting lipids and especially in triglycerides. We had beneficial changes in all CV risk parameters. And the most common adverse events were from GI. Nausea, vomiting, diarrhea. Step 2 was actually about diabetes. We saw in step 2 less efficacy on loose weight management. Step 3, we noticed the improved efficacy if we have additional behavioral therapy. And in step 4, we checked that what happens if we withdraw semaglutide in 20th week. And as we expected, we saw a gradual regain of weight after going to 68th week. Here is the two subgroups. We gave semaglutide till the 20th week, and then some of them stayed on semaglutide, some they took placebo. This is why the SELECT study is why we love semaglutide as a medicine, because we, in a 4-year period with semaglutide in SELECT study, we had 20% reduction in incidence of major acute cardiovascular events, and even 15% reduction in cardiovascular deaths, 18% reduction in incidence of heart failure events, and 19% reduction in death from any cause. And the second medicine we have, tirzepatide, is indicated for weight loss for BMI over 30 or over 27 if there is one comorbidity, and of course as medicine for the diabetes type 2. More or less we have the same indications as in semaglutide. Tirzepatide activates both GLP and GIP receptors. This is an old slide just to show all the SURMOUNT studies that support tirzepatide. All these studies have been completed right now. And we see the efficacy of tirzepatide in SURMOUNT-1, reaching 22.5% in body weight loss. We had good results in waist circumference change, also impressive, reaching about 20 centimeters. And here we see what happens if we withdraw tirzepatide. Those who switch to placebo experience a great regain of about 15%, while those who continued tirzepatide experienced additional weight loss of 6.7%. And after all this, it was very reasonable to have a head-to-head study, semaglutide versus tirzepatide. We see the demographics, and here are the endpoints. This evidenced the clear superiority of tirzepatide versus semaglutide in terms of weight loss. We see 21.6 for tirzepatide weight loss, 15.4 for semaglutide. You may see some difference. No, this is in percentage, and this is the actual kilograms, okay? And in key secondary endpoints, we see the mean change in body weight for participants in trial, and on the right is the mean, the average weight loss for participants in treatment. there were some participants that for some reason didn't adhere on treatment but continued to be in trial. And some additional endpoints, it is worth looking at it. We see there is a modest superiority of tirzepatide in several parameters. Here I would like to comment that despite the superiority of tirzepatide in terms of efficacy, semaglutide keeps a role on weight loss management because we can give semaglutide in adolescents, and we have clear evidence for heart failure. And anyway, in many cases, we do not have extreme goals to reach. Here are some general guidelines. It's worth mentioning here that the treatment should be continued even after having reached the goal, as we do in all chronic diseases. We can see here that we can use many medicines, but the most rational options for safety, for efficacy, for studies, for trials they carry is semaglutide and tirzepatide. And what about metabolic surgery? Why metabolic? It is more appropriate to choose this term because it has a significant role in managing not only the weight loss problem, but the metabolic factors like diabetes. And this is another reason why bariatric surgery or metabolic surgery appears to reduce cancer risks, and this must be advocated from all physicians if there is a need to proceed. And this is a question, what happens if we can combine the GLP receptor agonists and metabolic surgery? There are only real-life data that support the use of semaglutide and tirzepatide in the pre- and post-surgery period. It would be wise not to use them during the perioperative period, since there are some concerns for aspiration due to gastric emptying delay and the long half-life. In a pre-operational period, we can improve holistically the health of person with obesity, since we see that benefits start early after the beginning of treatment. In the post-surgery period, we can see benefits regarding the dabbing phenomenon, since the medicines delay gastric emptying. Personally, I have seen no major problems caused by the use of semaglutide or tirzepatide pre or post-surgery. A few words about the future. We must see the GLP-1 receptors as the backbone of medicines for weight loss. We know that until today, the surgical interventions are the most efficient way to lose weight. But in the future, there are plenty to come. We use the GLP, as I said, as the backbone, and there we may have plus glucagon or GIP agonists or antagonists. And in some trials, we have seen very, very extreme weight loss. But there are also problems with nausea and vomiting, the major side effects of these medicines. Thank you for your attention.